Okay, we are recording. So let's see, moving my pages here. So for those of you who are new to our TeleECHO and don't know me, I am Rhea Markowitz, and I am part of the Georgia Cancer Center Teledermatology Project, part of here in our hub. And Dr. Doug Patton and I will be serving as co-facilitators for today's TeleECHO session. And I would ask that everyone, if possible, have their screens on gallery view, if you have the bandwidth, during the time that we are all together, not sharing screens. A lot of the time we're sharing screens, but when we have discussions, we would like to be able to see everyone. So I want to start with telling, especially those of you who are new to us, about the teledermatology website that we have. The link is here on the slide, and this is part of our Teledermatology Serving Georgia program. And there is a lot of really good information on this website. The website's divided up into a section for healthcare providers and community, and I'm leaving something out, but there are several pages, and especially for you healthcare providers, there are some training videos about dermoscopy and skin cancers and dermatology, and you can obtain CME credit by watching those videos. You just click on the right button that says for CME credit, and then as you watch the videos, you can then apply for CME. We also have links to YouTubes of almost all, if not all, of our TeleECHO sessions that you can watch at will. You get CME credit if you're watching them participating live as we are now. You don't get credit if you're listening to or watching the recordings, but they are there for you. So if you're wanting to learn about a certain area, feel free to browse those YouTube, the titles and so forth, and help yourself to them. So I want to welcome everyone. I see a lot of unfamiliar names, so we've extended our reach, and I'm very pleased about that. So some of you are PCPs from the rural healthcare centers that participated in our original Teledermatology in Rural Georgia project, which was funded by the USDA Distance Learning and Telemedicine Grant Program. Some of you are clinicians that participated in that project and are starting to participate in the phase 2 project that we're doing now. I know that some of you are residents from the MCG Family Medicine Residency Program, and there may be some of our family medicine faculty out there. And I know that there are faculty and maybe some residents from our Department of Dermatology. So Dr. Loretta Davis is online, although she's tending to some cases. Dr. Kendall Buchanan and Dr. Harold Ravinovitz, all from the MCG Department of Dermatology. And let's see, there are probably some MCG medical students also out there. And then here in our hub, we have members of our hub team. So we have Brenda Santiano over here, who you've all gotten plenty of emails and correspondence with Brenda. So here she is in person on Zoom. and then also Ken Zimamuni, who's handling the controls here. We couldn't hold these TeleECHO sessions without our expert team here. So I, for one, thank both Brenda and Kenza. And we've had in the past, we've had some participants from across the globe, and I want to welcome if any of them are back on with us. And I want to welcome anyone who's attending for the first time. Spread the word to your colleagues. These Zoom sessions are open to anyone. So I think a lot of you have already started writing down in the chat, identifying yourself with your name, where your affiliation, and your email address. We need that for our records. So there are examples of all that information in the chat. So now I really want to welcome this next slide. I want to take the opportunity to recognize our own Dr. Brenda Santiano and other colleagues who run this SunSafe Augusta program. And they had there was ribbon cutting this morning in North Augusta for this project. This is a project that is a partnership with a nonprofit called Impact Melanoma and the Augusta Parks and Recreation Department here in Georgia, and then across the river in South Carolina is the North Augusta Parks and Recreation Department, and MCG and the Cancer Center all participate in this program. These are pictures from a ribbon cutting that we had last May in along the Augusta Canal, and in the lower corner is a picture of Mitch Hansen, a medical student who really initiated this part of the project, and of course Brenda Santiano, who helped him and coordinates all of this. And then in the upper right-hand corner is a picture of the at the ceremony, the mayor of Augusta, Garnet Johnson, and Mitch, and then Dr. Cortez, director of the Cancer Center. And this morning they had ribbon cutting over in North Augusta at a park. And what I didn't say was up there in the middle on the top row is what all of this is about, that this program has been putting up sunscreen dispensers along various trailheads and walkways. And you can, if you're going for a walk and you didn't put your sunscreen on at home, you can just stick your hand under that yellow device and get some sunscreen to put on. And down in the picture below is Mary Claire Regan, and I'm not sure who the little one is, but a cancer team member, and in front of one of the dispensers. So this is one way to prevent melanoma and other skin cancers, and the project has received funding from several sources, one of which is the Cancer Centers Unite in the Fight Against Cancer, and then that Unite in the Fight grant program is also supporting our teledermatology project these days. So we're very proud to participate in this, and again, we want to thank Brenda for all of her efforts in the program. So now we're going to look at today's agenda. We did our introduction, and our didactic presentation will be by Dr. Hannah Nazir, who is a PGY 2 or 3, I'm not sure. I think she's PGY 3, resident in the Department of Dermatology, and she will speak on rosacea. And then we'll have a case presentation by Andrew Chang, a fourth-year medical student, and at Medical College of Georgia, of course. And so now is the time that I turn the program over to my colleague, Dr. Doug Patton, and he'll continue with today's session. Dr. Patton is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia. And he spent most of his career as a rural physician and has been a great part of the teledermatology program. So, Doug, I turn things over to you for a while.
Thank you, Rhea. It's good to be back. Welcome, everyone. Looks like we got a great crowd gathered this afternoon. Lots of family medicine residents from Wellstar MCG. We've got med students. We got our East Georgia Health Center folks represented well, including somebody from one of my favorite areas that community health centers provide care, and that's from your school, one of your school-based health centers. So that's an incredible representation on our first day out. It's my privilege to kind of run through some of the rules of the road here and the basics of why we gather for these regularly scheduled meetings. And so Project ECHO stands for Extension for Community Healthcare Outcomes, and the tagline is moving knowledge instead of people. This is an improvement in knowledge in this series, focusing on teledermatology and teledermoscopy, and we hope that you'll take advantage of those archived videos and previous programs so that you can kind of learn some of the tricks, if you will, of teledermoscopy, and ultimately we can provide some teledermatology backup for all the primary care providers who are interested in doing that, helping you to manage cases where the patients are with the assistance of dermatological expertise, but not necessarily having to send the patients away for a full consult. The reason for this is that we know that people in some of the smaller communities around the state where you provide the services, there are the existing disparities sometimes prevent people from being able to access advanced care away from their home. So next slide, please. This is for education and quality improvement processes. So that's why these sessions are recorded. By staying online, you are consenting to be recorded. We do appreciate that participation. But as a reminder, this is not a consultation. It's not secure, and it is recorded and archived. So please do not mention any PHI in the discussions. There will be information in the slide and in the chat about CME and CNE. You can also get that information from the website for the teledermatology program. You can always email questions to teledermatology@augusta.edu, and you can also put stuff in the chat anytime along the way, including questions for the presenters. Next slide. We do collect data about, it begins with registration, who's participating, any questions and answers, all the chat comments. And if we have polls during the presentations, the poll responses are also recorded. This helps us to be able to share information not only amongst ourselves, but with the entire global audience that has access to these ECHO programs. Next slide, please. So just a reminder, as she shared earlier, mute your microphone when you're not talking, unmute when you do speak, type questions into the chat. If you want to ask a question verbally, there's an electronic hand button. If you look at the React button at the bottom of your screen, click on that. It'll give you the opportunity to raise your hand. We'll recognize you if we see that. And then introduce yourself, your name, your clinic, who you represent, and then ask your question. Again, as Rhea pointed out earlier, it's nice if you can leave your camera on all the time so we can see everyone's faces during the presentations. If you have bandwidth challenges, we understand that's not possible. Again, please use the chat or email Kenza if you have technical issues during the presentation. Next slide, please. So it's my pleasure at this point to introduce our first speaker for the year, Hannah Nazir, who is a PGY3 dermatology resident with the MCG dermatology program there at Augusta University in Augusta. And she's going to talk to us today about rosacea. and she'll correctly pronounce that if I didn't get it exactly right. So
Perfect. Thank you, Dr. Patton, for that introduction. Let me just share my screen real quick.
that's quite a stack of microscopes you got there behind you.
Yes, it's our very special multiple-headed microscope. Yes.
And a ping pong table on the conference table as well.
Yes, we prioritize our resident wellness, so we've got our ping pong table as well.
It's impressive.
Right, can everyone see my screen okay?
We can, it's still in, we can still see your notes. I'm not sure
Okay,
that
let me see.
cleared up last time.
Does that look okay?
That's great.
Perfect. So again, thank you everyone for joining us today. I just wanted to say that the TeleECHO really is such a fantastic initiative. So thank you to everyone who does such a great job of putting this together. But yes, so my name is Hana Nazir. I'm a PGY3 resident with MCG. And so we'll be talking all about rosacea today. I have no conflicts of interest to declare. And so we're going to start off with kind of a vignette. So suppose this patient comes into your clinic. She tells you her eyes feel really dry and gritty. She feels like there's always something kind of inside of her eyes. She tells you she's been getting these, acne-like bumps, and she's in her 50s. She has very sensitive skin. She tells you that, no matter what kind of product she puts on her skin, it causes her to feel this burning, this stinging and pain on her face. And she tells you that she tends to flush and blush really easily. So if your patient has, any constellation of these symptoms, your patient could have rosacea. So rosacea classically is a skin condition that tends to affect adult women. So usually people over the age of 30, and in Fitzpatrick types, skin types 1 or 2, with the caveat that sometimes you can get these, what we call these phymatous changes, where if you look at the nose on the right, you see that there is some thickening of the skin due to the overgrowth of sebaceous glands. And so these kinds of changes we usually see more in men, but overall it is a disease that tends to affect adult women more commonly. And the pathogenesis of rosacea is really multifactorial. So there's a component of vascular hyperreactivity. There's a role in innate immunity that gets dysregulated. Chronic sun damage plays a big role. And in the bottom right, you see the Demodex mite, which again lives on all of our skin, but in some patients you can have increased levels or infestation of these mites, which can also play a role in the pathogenesis of rosacea. And along with these factors, there are different triggers that can cause patients to flare up. So when you're screening a patient for rosacea, triggers that I would ask about are, does hot weather, being outside in the sun, just drinking alcohol, eating spicy food, being outside in really windy environments, are these factors that tend to flare up your skin. In addition to these really common triggers, there are things like, certain skincare products, medications, even certain fruits or meats or vegetables can also play a role. But what you see on the screen with weather, sun, alcohol, and food, these are really the most common triggers that we see associated with rosacea. And so when it comes to diagnosis, rosacea technically requires at least one diagnostic or 2 major phenotypes. So for diagnostic phenotypes, this includes having erythema, this redness in the center of your face that's really fixed. And I'll show you some pictures of what that looks like in the upcoming slides. So the central facial erythema that tends to periodically intensify, or having these phymatous changes. And so that's what I mentioned earlier, where the skin can take on this sort of thickened appearance, where the nose, for example, can look really bulbous and have these kind of surface change. You can also have major phenotypes, so things like papules and pustules, flushing, telangiectasias, or these dilated blood vessels, and then, eye symptoms. So symptoms like, telangiectasias along the lid margin, conjunctival injection, feeling, this dryness or grittiness or foreign body sensation in the eyes. And then along with these diagnostic or major phenotypes, we have, secondary symptoms that can accompany this. So symptoms like burning, stinging, some facial swelling, just an overall dry appearance. And then other eye symptoms like eye crusting, scale accumulation along the lashes, irregularity of the lid margin. So in general, rosacea has 4 major kind of categories that you can group it into. This includes the erythematotelangiectatic variant, papulopustular, phymatous, and ocular. Though I will note that a lot of patients can have overlap between these subtypes. So you can have a patient that has, a papulopustular rosacea along with ocular symptoms, and really any combination of these. But I will say it is important to be able to identify what kind of subtypes a patient has, because that does really help inform the kind of treatments that are helpful for these patients. So we'll go through each of these in a little bit more detail. So what you're looking at here is what we call the erythematotelangiectatic or vascular subtype of rosacea. So if you look at her face, she has this erythema, right? This redness along her cheeks and her nose, really in the center of her face. And so these patients will have this kind of fixed or recurrent flushing that can eventually become permanent flushing. This flushing can also be accompanied by a dry, burning, stinging sensation, just skin that's very easily irritated. And you can also see some telangiectasias, so some dilated blood vessels, which you can't really look from this far away, in this picture, but they can be more prominent in other patients. So this is that first vascular variant of rosacea. The other variants we can look at are what you see here. So again, if you look at the nose in this patient, this is a phymatous change on the skin. So again, phymatous meaning that there's thickening of the skin due to overgrowth of the sebaceous glands. We usually see this on the nose. We call this rhinophyma, but you can also see this kind of change on the chin, the forehead, the earlobes, the eyelids, but again, most commonly on the nose. And I want you to kind of look at this picture of the nose and really kind of burn it in, because a common misconception that people can have is that this kind of change on the nose is associated with alcoholism, or this is a patient that has like a substance abuse problem. But just be aware that it really is probably just a component of their rosacea. The other finding that you can probably see in this picture is if you look at his eyes, his ocular conjunctiva are really injected. There is some erythema along the lid margin. So this patient probably has a component of ocular rosacea as well. And I really want to highlight ocular rosacea because actually 50% of patients with rosacea can have these eye symptoms. And it can be really confusing because a lot of patients will have this, burning, stinging, tearing in their eyes, and they won't even realize that it's actually related to rosacea. And so they may not even bring it up to you in the clinic visit. And so if you are concerned that a patient has rosacea, just always, screen them for these ocular symptoms as well. So moving on, a big question that, can come up is, you have this patient with these erythematous papules and pustules, how do you really distinguish this from acne, right? So there are a few features that can help you distinguish rosacea versus acne. The first thing I would look at are, the patient's context. So with rosacea, we usually see this again in adults, older women, whereas acne, traditionally you see this in, or see this starting off in younger patients. The other feature that's really helpful to look for is the presence or absence of comedones. So comedones are, your whiteheads, your blackheads. Basically, it is a comedo is a plug of keratin and sebum in a dilated pilosebaceous canal. So, with acne, as you see in the right, this patient has these, open and closed comedones on her forehead. Whereas with rosacea, importantly, you will not see comedones. The other factor that can be helpful is looking at distribution. So rosacea, classically, you see it in the center of the face, whereas with acne, you can see it on the forehead. And then you're also more likely to have upper trunk involvement, so involvement of the upper chest and the upper back. So next we'll talk about management, which I think is really kind of the most important aspect of this. So with rosacea, there are certain general recommendations that I would say should apply to every single patient with rosacea, and it's really important that you counsel your patients kind of on these general recommendations. So the first thing is really ensuring that they have very gentle skincare. So using moisturizers that have ingredients like glycerin, occlusive like petrolatum can be really helpful in these patients. So for example, again, there are several brands that are great, but an example is Vanicream, which has a great line of skincare products for sensitive skin. CeraVe, for example, has a healing ointment with petrolatum that can be helpful in these patients. And really, talk to your patient and see what products they're already using at home. Because a lot of the products that they may be using at home to treat their quote unquote acne could be really aggravating or irritating their skin. So make sure they're not using like astringents, things that are drying out their skin, toners, exfoliators, especially products and cosmetics that have fragrances or alcohol can really trigger their rosacea. So just kind of sit down with them and see, what their skincare regimen is at home. The second big component is sun protection. So sun exposure, as I mentioned earlier, can be really a leading influence on the development of this flushing and erythema. And so always counsel your patients to use sunscreens. Specifically, what tends to work a little bit better in rosacea patients are mineral-based sunscreens. So sunscreens that have ingredients like titanium dioxide and zinc tend to be better tolerated. They provide more of a physical barrier than chemical sunscreens that could be a little bit more irritating. So these sunscreens work great, at least an SPF of 30. And then wearing a broad brim hat when you're outside. And then I will also mention there's a supplement called Polypodium. We really like to recommend this to our patients. It's a natural fern-based supplement that you can actually get over the counter. There are different brands that sell this, like HelioCare, but essentially you just counsel your patient to take like a capsule about 30 minutes before they go outside. They can repeat this 2 to 3 times a day, and it's really a great option to supplement your sunscreen, your hat, your long sleeves. And just to say, we like this not only in rosacea, but really any patients that are sun sensitive or like to spend a lot of time outside, or they have a lot of sun damage. It's really a great option to for these patients. And then of course asking them to avoid potential triggers can also be a benefit. So now that we have our general recommendations, we'll talk about some more targeted therapies. So for this erythematotelangiectatic rosacea, it's a little bit tricky because the topicals that you classically use for rosacea, like metronidazole, azelaic acid, don't really work that well for specifically the flushing and the blushing. And a lot of these topicals can be a little bit irritating. So if your patient just has, again, the flushing and the blushing, using metronidazole or azelaic acid may not really work as well. There are other topicals that can be used to control the flushing. These are things like brimonidine gel, oxymetalazone cream. These basically work by constricting the blood vessels. The caveat with these topicals is that they are temporary. So they have a maximum effect of up to about 12 hours. They work the best at around the 3-hour mark. And really the big thing that I would counsel your patients about is that there's a risk of rebound of the erythema once that effect wears off. So, these topicals could be a good option if your patient has like a wedding or some event where they want to temporarily control the flushing, but just be aware that once that wears off, the erythema can really come back and be quite prominent. And I'll show you a couple of pictures in a couple of slides. So in addition to topicals, there are some non-selective beta blockers that are sometimes used off-label. So medications like nadolol, carvedilol, propranolol have been used with some benefit for flushing. And then we also have lasers. So there's a pulse dye laser, which we actually have at MCG, the KTP laser. And so these can also be used to help with redness. The other point I want to highlight with brimonidine is that it's quite expensive. So this is, for example, looking on GoodRx, the cheapest option that we have, with insurance is around $300. So just be aware that, again, it's a pricey medication that doesn't really work, in the long term. And just to show this further, this is a patient in a case report. She has a little bit of baseline erythema on her cheeks. You can see she then applies the brimonidine gel. At 2 hours, it's working really well. Her skin flushing is definitely improved. At 12 hours, that effect is starting to wear off. And then at 24 hours, she actually has some rebound. The flushing is actually more prominent than it was at baseline. And this rebound can actually last several hours afterwards. So again, it's fine to use in certain situations, but patients should just be aware of this potential side effect. All right, next we'll talk about topicals for papules and pustules. So if you look online and you look up like what topicals are available for this variant of rosacea, you'll see a very long list. It can be a little bit overwhelming. And so there is a kind of a paper that was published by the National Rosacea Society where they compared different topicals and looked at the level of evidence for each of them. And the ones that have the most evidence are ivermectin cream, azelaic acid gel and foam, and then metronidazole, which comes in different vehicles and a couple of different strengths. But essentially, these three have the most evidence. When you're comparing between the three, ivermectin has slightly more efficacy than, or has been found to be slightly more effective than metronidazole. Azelaic acid, the caveat with that is that it can be a little bit irritating, so may not be the first thing you jump to in patients that have sensitive skin. And then the metronidazole, between the cream and the gel and the lotion, they have found that the efficacy is pretty similar between the three vehicles. So in practicality, what do we actually reach for initially? Most of the time, we just go for the topical metronidazole, just because it's more likely to be covered by the patient's insurance off the bat. So the 0.75% gel and cream, we've had, it's been available for years. It's been available in a generic form, so usually don't have any trouble getting that. I will say the lotion is probably more likely to be drying and irritating. When you're starting off, I would probably reach for the gel or the cream initially. And then the 1% metronidazole gel, there's some formulations that have niacinamide that can be helpful for redness. But again, insurance may require you to try and fill the 0.75 first. And then just to say about ivermectin, ivermectin is also topical that, insurance may require trying and failing, other topicals first. So moral of the story is start off with metronidazole gel or cream. And then if that doesn't work, you can kind of think about these other topical options. I do want to highlight the fact that you can actually get these three components compounded together from a compounding pharmacy for about $45, $50. So if your patient is willing to pay that cost, it could be a good option to offer them. Next, I'll talk about ocular rosacea. So as I mentioned, the symptoms can be really frustrating, this constant tearing, burning, crusting. So you see the patient on the top has prominent erythema around his lid margin. So in patients that are not doing well with basic lubricating eye drops, what we really like to use is low-dose doxycycline. So it's just 20 milligrams BID. You could do 40 daily, but it's more likely to be more expensive than the 20 BID, so that's usually what we do. And what's really nice about low-dose doxy is that it's a sub-antimicrobial dose, so you're not going to have the same side effects or adverse effects as you would with like 100 milligram BID dosing. And it's actually safe to use as maintenance therapy for in the long term. So we really do like to use it. So not only for ocular rosacea, but also in patients that maybe aren't responding as well to topicals alone, it could be a great option to add. Also for ocular rosacea, just want to make a plug for tea tree oil. So as I mentioned, the Demodex can play a role in the pathogenesis of rosacea. And they've actually seen that patients with rosacea can have higher rates of Demodex infestation in the eyelashes, especially in the papulopustular variant. So a really great over-the-counter option is tea tree oil, which you can get from Amazon. For example, Desert Essence tea tree oil. It has antibacterial, antifungal, antiparasitic properties. And essentially all your patients have to do is they make a little lid scrub. You mix 1 part tea tree oil with 3 parts baby shampoo. You scrub the eyelid margins and you rinse, and that can be a great complement to their other therapies in case that they do have a component of Demodex infestation. And then finally for rhinophyma is a little bit tricky to treat with just topicals. That doesn't really work as well. So you can do low-dose isotretinoin with some efficacy. A lot of times you really do need more of a procedural intervention. So CO2 laser works really well. This patient on the right had really great results with CO2 laser. You can do electrosurgery, surgical excision, but again, it does require more of a procedural intervention to treat this. All right, so overall, if you take anything away from this, just keep in mind that when you're treating rosacea, less is more. Really stick to the basics. So if they come in for their initial visit, make sure that they're using the most gentle skincare. They're not using any extraneous products that could be just flaring up their skin. Make sure they're protecting their skin from the sun. And then if they're not getting better, you can slowly add on your topicals or your doxy if you need to. But I think really sticking to these basic principles will really take you far with rosacea. Any questions?
Thank you, Dr. Nazir. That was very, very interesting. And I was looking at the chat. I didn't see any questions over there. We certainly have a couple of minutes if there's anyone in the audience who has a question. We can take a couple of minutes before we move on to our case presentation. I will say that I made a couple of notes as we're going along. First of all, I don't know how I missed it, but I didn't realize how important that the Demodex mite was as a contributing criminal, if you will, here for this. So I wasn't surprised when I saw ivermectin cream also listed as one of the treatments, and tea tree oil I did not realize had antiparasitic inhibitory things. But being able to safely treat for the parasite obviously has to be a key element, at least something worth trying for everybody, I guess. Is that fair?
Yeah, absolutely. I mean, it's kind of interesting because we all probably have Demodex mites on us, but there has been a lot of data that shows that it plays a role in Demodex blepharitis, even in the skin manifestation. So yes, that's a great point. The antiparasitic effects of topical ivermectin, probably play a role in controlling the, not only for the other components of rosacea, but also the Demodex mites as well. So yeah, absolutely.
That's great. Jennifer, I see you have your hand raised. Go ahead.
Hi, yes. I know in clinic there was a case of sarcoid where it manifested with kind of like a nodular appearance on the nose. And I wanted to know what the best way is to tell that from the phymatous rosacea presentation.
Yeah, that's a great question. Certainly, I mean, the nodular appearance with like a granulomatous process like sarcoid, I can totally see how that looks similar to, that kind of bumpy appearance of the nose with rhinophyma. I think there are a couple of things. One is you have to think about like patient demographics, right? So rosacea, again, typically Fitzpatrick types 1 or 2, older females, they probably have these other associated symptoms as well, right? Like the redness, flushing, blushing, that's telangiectasias. With sarcoid, you're more likely to see these kind of firm like plaques or nodules, probably not the same patient demographic, probably don't have those other associated symptoms as well. So, but yeah, I would say if you're looking like at an isolated picture of just the nose and you have no other patient context, it could be difficult to distinguish. But again, like the full patient history should help you with that.
All right, great. Well, I don't want to compromise Andrew's opportunity to share his case, but put a pin, if you will, in that Fitzpatrick conversation. I'd like for us to come back maybe and talk a little bit about presentation in darker skinned individuals if we have a few minutes at the end. So It's my privilege now to introduce Andrew Chang. He's a fourth-year medical student at MCG, and he is going to share a case with us today. So, Andrew, if you're ready, you want to go ahead and share?
Sure. Thanks for the introduction, Dr. Patton. As you mentioned, my name is Andrew Chang. I'm a fourth-year medical student coming from the Athens campus. And today I'll be presenting a case of a dermatologic problem called curly disease that can emerge in patients with systemic diseases, but especially late-stage kidney disease. You might see it in the literature referred to by the name acute perforating dermatosis, but for the sake of consistency, I'll be sticking with the term curly disease today. I have no financial relationships or conflicts of interest to disclose. So moving right along to the case, our patient is a 45-year-old male with medical history significant for chronic kidney disease, secondary to type 2 diabetes. Started on 3 times per week dialysis within the past couple of months. Fairly typical to any general medicine clinic. He does present with these severe itchy papules with erythematous base that are unrelieved with over-the-counter creams. Been going on for a couple of months now. You can see them on the right of your screen here. They feel firm and have a central keratin plug on dermoscopy, which we'll see in a little bit. He's also complained of some less itchy but still painful areas on his back and his legs. This unique appearance in a patient with CKD and type 2 diabetes should immediately raise some suspicion for curly disease. So here I have a closer view of these lesions where we can really see their distribution focused on the extensor surfaces of elbows and knees and their morphology, which are these, again, firm, rough, centrally umbilicated papules, some clustering, almost coalescing into plaques. On several of them, we can grossly appreciate a central keratotic plug. We can really start to see that here on dermoscopy. The most important finding is that central keratin plugging, but we can additionally see some broken hairs, evidence of excoriation on the left figure, and on the higher magnification on the right. On that other papule, we can also see some red dots on a white background. Those dots are blood vessels, and the shiny white lines surrounding them may indicate fibrosis. The broad takeaway here, though, is that dermoscopy cannot be practiced in a vacuum. In isolation, any of these individual lesions, particularly that papule on the right, might be mistaken for a squamous cell carcinoma or a prurigo nodule. But given the clinical context, the distribution, and the constellation of features, especially that central plugging, we're definitely leaning towards curly disease at this point. So moving towards a diagnosis, we performed a lesional punch biopsy, and the results are concerning for a perforating dermatosis. There's 4 perforating dermatoses described in the literature, which are linked mechanistically by the transepidermal elimination of skin components. However, our biopsy results are concerning for these 2 on the screen here, curly disease and elastosis perforans serpiginosa. So I'll be focusing on those 2. In curly disease, the leading hypothesis is that systemic illness, such as chronic kidney disease, combined with localized skin trauma like scratching, drives the transepithelial elimination of keratin. In our case, we believe their curly disease began when their CKD took a turn for the worse. As I mentioned earlier, they started hemodialysis within the past couple of months. On the right here, I also have a demonstration of how curly disease might manifest on an individual with darker skin. Okay, so, and again, contrasting this with elastosis perforans serpiginosa, or EPS, that's caused by elimination of elastic fibers rather than keratin. It's also associated with a number of genetic disorders, such as Marfan disease, Ehlers-Danlos, osteogenesis imperfecta, rather than systemic kidney disease or metabolic disease. It's most commonly located on the neck, as we see here, and it forms these thin erythematous papules which coalesce into serpent-like or serpiginous forms, hence the name. So diagnosing curly disease in this case is a matter of putting together the constellation of features. The biopsy, initially ambivalent in our case, becomes diagnostic as we put together that clinical context of late-stage kidney disease. So management, our first step in clinic was to provide systematic relief for the itch, as we described here with clobetasol. But the patient's symptoms have improved greatly with dialysis, which leads me to the true first step of management of curly disease, which is management of the underlying condition. So their curly disease has continued to improve alongside their kidney function, and we expect that to continue as long as they attend their dialysis regularly. There have been cases of people developing curly disease secondary to hepatic or cardiac causes. So in a patient without an obvious predisposing history, it is important to work them up further. I'll open the floor up to any questions or discussion now. Thank you.
Thank you, Andrew. That's very interesting. It's actually something that I've never heard of, but people surprise me all the time, so that's wonderful. Any questions for Andrew about that?
So, Andrew, I like the fact that you brought up dermoscopy in terms of some of the findings with Curly's disease, because you can do the same with these other neoplasms as well. For example, with rosacea, it's characterized by these vessels, which are very sharply in focus. They're polygonal over an area of erythema. The rhinophyma that you see often has a sebaceous component, so you'll see lots of yellow, as opposed to sarcoid, where it has an orangish hue. So dermoscopy can help you with some of these neoplasms, as you showed with Curly's disease.
Great comments, Dr. Rabinovich. Thank you for adding that context and also putting in a plug for dermoscopy again. So we appreciate that. Any other comments or questions about Andrew's case in particular? We can open it up in just a minute for go back and revisit some things with Dr. Nazir as well. Andrew, on one of your slides there, it looked like on the neck of the individual appeared to be almost a circular formation of the outbreak. Has that I guess it's possible that if those things were coalescent, it wasn't stereotypical, might actually confuse that with tinea if it's in the right location. Am I stretching things too far?
Yeah, I definitely see what you mean. And when I found that photo originally, it's definitely it was in the back of my mind. Just bringing that up again. I think in our case, if you are concerned about elastosis perforans serpiginosa, I think you would think about is this responding to an antifungal? Is this progressing or going away over time? And do they have any of these clinical risk factors, these congenital conditions which might predispose them to EPS, Marfan's, Ehlers-Danlos, osteogenesis imperfecta?
Sure. All right. Thank you. Shinyer Omet has a question. Given that curly disease is often seen in patients with systemic conditions, as you mentioned, diabetes, chronic kidney disease, is it primarily a cutaneous manifestation of a systemic disease, or could it represent a distinct dermatologic disorder with its own pathogenesis?
Yeah, that's a great question. The pathogenesis, the pathophysiology of curly disease is not actually fully understood right now. The leading hypothesis is that it is a cutaneous manifestation of systemic disease, as you described, that it's sort of caused by urea buildup under the skin, which causes in turn that abnormal keratinization and transepithelial elimination that I described. But because it is on the rarer side, it's difficult to study.
That's great. Thank you. Well, I want to go back before we run out of time and just ask Dr. Nazir to talk briefly, if you will, about some of the maybe the different ways that rosacea will present in darker skinned individuals with the higher Fitzpatrick scores and things like that. And if so, are there differences in how it might be treated?
Yeah, that's a great question, Dr. Patton. So it is a little bit tricky because I would say about probably 2 to 10% of patients with rosacea have Fitzpatrick types 3 or 4. I think another question that this raises is whether or not we're just maybe not like underdiagnosing these patients due to difficulty in picking up the subtle differences in erythema or the telangiectasias. From what I have read is that patients with Fitzpatrick types 3 or 4 are more likely to have the granulomatous variant of rosacea, or these papules and pustules. To my knowledge, how you would treat these patients, doesn't differ too much from, other patients with rosacea. But I will say, with any kind of, case with skin of color, you just have to be careful about, avoiding products that could irritate the skin and lead to post-inflammatory changes like post-inflammatory hyperpigmentation or hypopigmentation. So I think just being more cognizant about, not causing further inflammation that can lead to these secondary changes is important. But at least to my knowledge, I don't think that it, significantly changes the treatments that you use.
That's great. I do appreciate you bringing up the idea of like being mindful at least to avoid some of the inflammatory things that could lead to hyperpigmentation as it resolves, which we know is worse in darker skinned individuals. Well, thanks very much. I don't see any other new questions out there. I cannot end this first session back without seeing if our dear friend Dr. Loretta Davis has anything to contribute to these great presentations. I think
Okay, I'm here. I've had to go see 2 consults in the hospital intermittently between these
Oh my
presentations.
gosh.
But I've actually been listening the whole time. And no, those are both great presentations. Just, rosacea is so common. It's such a practical thing for people to understand. And I think that Dr. Nazir's presentation is extremely useful. I think sometimes it is underdiagnosed. And regarding curlies, it's rare, but it's very real. And we do see it in our dialysis population. It's extremely itchy. And when you make those folks better, they are so appreciative. We sometimes do use a drug called acitretin for that, which is kind of a cousin of isotretinoin, which is used for acne. And light therapy can be very helpful. So sometimes we'll put people in our light box. So it's very real. And you don't want to miss it. People will misdiagnose it as scabies, and as eczema. But if someone has renal failure, you need to be thinking about Curley's disease. So opposite ends of the spectrum when it comes to frequency and commonality, and both were very well presented today.
That's great. Thank you for that wrap up, Dr. Davis. And with that, Rhea, I'm going to turn it back over to you to close out the session.
Okay, well, thank you. First of all, what a great showing that we have for our first session of this season, I guess. We have, I think, about 45 attendees, which is really just great. And thank you to Dr. Nazir and to Andrew for great presentations, something we haven't talked about yet. So for those wanting CME credit, let's see. Oh, well, on the next slide, but we don't get to it yet. The code will be there, and it's also, I think, in the chat, and you'll get it by email. But our next TeleECHO session will be on October 6th, which is the first Monday of the month. And this is where we have some exciting news going on. So for the next few months, we will have a series of presentations by Dr. Elizabeth Vinnie Cyberling. She goes by Vinnie. And she will be talking on topics relating to dermoscopy and skin cancer and rashes. She'll have with a focus on PCPs and medical residents. She is the director of teledermatology for the Rural Access to Dermatology Society, or RADS. And this is a group whose mission statement is to understand the barriers that limit rural patients from visiting a dermatologist and devise systems to positively impact the skin health of this population through education and research. And when I read that, I just thought, well, this is so much in line with our teledermatology serving Georgia project. So I think this is a great marriage of sorts. And Dr. Cyberling is also Associate Professor of Dermatology at Tufts University School of Medicine in Boston. She has practiced in the state of Maine, and she also ran a dermatology Project Echo program in Maine. So she's very familiar with what we are doing, and we're excited that she will be joining us on October 6th. She will talk about high yield skin cancer pearls. So I hope you will all come and join us then. Also, any of you PCPs out there who would like to do a case presentation of something you've seen and maybe you're perplexed about it, or wanting to know, did you do the right thing, or want any kinds of advice, we would love to have you do a case presentation. So if you are interested, please contact Brenda or email us at teledermatology@augusta.edu. We would be happy to have you do case presentations. So thank you all for attending today. It's been really a great way to start off the fall season, and hope to see all of you again on October 6th. And a reminder to the Teledermatology Hub folks to stay on for a few minutes afterwards, just for a little bit of debriefing. And the rest of you, you clinic folks and other guests can sign off now and go back to work, or head on out. So thank you for being